It's the anticipation or fear of discrimination and an awareness of negative attitudes and actions related to lung cancer. There's influences of the effectiveness of patient-clinician communication. We've seen a huge impact. I've talked to patients in qualitative studies, I've surveyed them in quantitative studies, and they've told me time and time again that their communication with you as nurses, with clinicians of all kind, have been impacted by attitudes and by stigma. We're going to talk today about how case finding and treatment are impacted. Stigma contributes to the burden of illness. I've done several studies now. We developed a tool to be able to measure it. We found that indeed stigma does contribute to the distress of the lung cancer patient. But we've also found that lung cancer stigma contributes to the symptom burden of patients, not just the psychosocial symptoms, but the physical symptom burden. And we've started to look at what are the mechanisms under that. What is that about? But we also know that stigma is amenable to intervention. And when we do intervene, there are positive health outcomes. So clearly, in the studies that I've done, in the studies I've seen other people do, the prevalence of perceived lung cancer stigma is high amongst patients, and for many different reasons. And the stories that they tell us are painful stories. But remember what I told you was that stigma can be identified and it can respond to intervention. But before I go on, I want to tell you, I love to blame it on the tobacco industry. I have a tobacco control background as well. And I want you to know the role of the tobacco industry in the development and the creation of this stigma. You know, the industry convinced smokers that they chose to smoke. They convinced smokers that they knew the risks. All they did was choose it. Not that they were addicted, they chose it. And they spent decades and millions of dollars to conceal those risks. So there's really 2 points in time that contribute to delay. One is between the first experience of symptoms and reporting them to a clinician. Insufficient research to explain this delay. We don't have enough research. I can't report it to you because it's not there yet. There's several studies that are being done. We've argued that diagnosing lung cancer early will have a minimal effect on reducing mortality. I don't buy it. But it is the truth that people do not develop symptoms until the cancer is in an advanced stage. But we have to have a new way of looking at lung cancer symptoms, a new way of understanding them, and a new way of assessing them. And then the second point, enter lung cancer screening. In the past 2 years, we've had a major breakthrough. People do not know the facts about screening. If people are going to be screened, they have to meet the criteria for high risk. People who are current smokers, they are high risk. Or if they have quit within the last 15 years, if they have a history of smoking, age 55 to 79 years old, with a 30 pack years or greater. So yes, we're coming out of the shadows, we're going into the clinic. We need to educate, educate, educate. And one of the best quotes that I came across that I'm going to give to all of you that you can use with your patients. It is important to remember that your doctor does not necessarily think you have cancer if he or she suggests a screening test. Screening tests are given when you have no cancer symptoms. Eliminate stigma. If you have lungs, you can get lung cancer. I don't care what you've done or who you are, you can. And we have to help patients communicate with public and providers.